So we hear a lot about HIV prevention in jurisdictions and what's been happening. I'm Kay Hayes with HIV.gov and delighted to be here with two colleagues and friends, Janet Cleveland from CDC, Steve Young from HRSA. Welcome. And I want to say hello to our viewers out there listening in. We encourage you, if you have questions, send them in to us as we have our conversation. So as we talk about today at the 2018 Ryan White Conference on HIV Care and Treatment, we heard a session earlier today, that talked about jurisdictional approaches and what's been happening. And most importantly, we want to hear the conversations of what you guys heard in an earlier session. We want to talk about the efforts that are being done in 3 jurisdictions. So what did you guys hear today about what's been happening around the country?
You want to go first? Or
Sure. I think what resonated with me the most was the whole concept of the importance of partnerships in general.
Okay.
Talking with people who you are familiar with, but those that you are not maybe as familiar with as well, in terms of trying to be comprehensive in looking at different ways to reach our goal of no new HIV infections. So we've always known within this line of work that partnerships were important, but I think when it comes to specifically talking about ending the epidemic, it's increasingly become more important for us to do that.
Yeah.
So we heard about partnerships, and Steve, what else did you hear?
Well, I just want to add it to the partnership because we actually saw 3 different types of partnerships this morning. We saw county, city, local was partnering with the state. We saw in one jurisdiction the public health department partnering with a community-based private law firm. And then we saw a task force that formed locally in Fulton County, Georgia, which incorporated folks from academia as well as community-based organizations. So all sorts of different partnerships. There's no one right way, but partnerships is clearly important. The other thing I heard about was the critical importance, both at the beginning and in an ongoing way, of community and stakeholder engagement.
Absolutely.
So you need a variety of partners to stimulate action, to maintain that initiative, and then see it through so that you have some meaningful health outcomes.
Right. That's exciting. So we heard partnerships, we heard community engagement. So what kind of best practices or things that we could share with our viewers here that you guys hear about?
Well, to build on, I guess, your initial question, one of the other things that clearly came across was the importance of being data-driven in terms of developing plans, in terms of program planning in general. And so I think that is really important in terms of lessons learned, and just for people to get more into the understanding of how important it is to let data drive what you're doing. Right. So we've always talked about the importance of local epidemiological profiles. You know, that's been kind of like a standard in terms of planning for both prevention and care.
Sure.
But I think now we're at a point where we can actually use data in a way that helps drive planning further, that helps us identify persons who are may not have been identified in terms of being in care, and to help them to get into care. So there's so many different ways that we can use data, but it should definitely drive the entire conversation from beginning to end.
And I think we saw some examples of data-driven approaches, both at a very specific level as well as a high level. So I think you heard a couple of the jurisdictions talk about the need for comprehensive sexual education in schools, because they've seen the data, and the greatest increase in new infections is in that younger age group, school-age children and post-high school-age children. From one of our other jurisdictions, they looked at a whole host of data points and identified the fact that black, gay, young men had some serious health disparities. And so their Ending the Epidemic plan started out by focusing on that target population and what could be done to understand their needs and how to access HIV testing as well as entry into the healthcare system for those who are positive.
Right. So when you were sharing information and the jurisdictions were sharing information, what was the feedback from the audience?
Well, to be honest with you, it was rather difficult to see the audience, to be honest with you. Feedback that we've gotten since the session ended, though, seems to be positive. People appreciated the concept of the conversation, and appreciated the way the jurisdictions actually presented their information and the information that they provided seemed to be quite helpful.
And I have nothing definite to go on, but again, based on some conversations in the hallways afterwards, I really think that the majority of the audience did take away something that will help them either to start an Ending the Epidemic initiative or if they've already started to improve upon it. Because clearly there were a number of different approaches and different ideas that people could draw upon.
Right. Well, one of the things I think is so important that I know CDC and HRSA has been doing is this integrated planning.
Oh, yes.
And so I know you guys have been entrenched with that. Let me hear a little bit more about the integrated planning and how that made an impact and how, what we're doing, how things are going.
Yeah.
Well, it's been an interesting process. More people are actually talking about integrated planning now. I think it's become a part of our HIV lexicon, if you will, now, which is really great. But the process started, oh my gosh, probably
2015.
That's when we first started writing, and the planning started before then. So the first integrated plans for both the Ryan White programs and the CDC programs were due in September, I believe, of 2000.
Ability with those plans. So I think overall we actually got 80 integrated plans bridging the prevention care continuum, but they came in different forms. So, we have both states and cities that are funded under our various programs. So we care city and state. And then we actually had, because it was an option, we had 21 Part A funded jurisdictions that came in with a city or county only plan without the state. And they did that quite honestly. We gave them that flexibility, but they were drivers of the epidemic in their state, and they felt that an individual plan would be a better roadmap for them, because that's what this really is. It's the jurisdictional roadmap. It's not our plan. It's something that the jurisdictions use as a roadmap for their planning and programming.
Right. So for our viewers listening in, I'm Kay Hayes with HIV.gov, here with Janet Cleveland from CDC and Steve Young from HRSA, and we're talking about jurisdictional approaches to HIV prevention. We've been talking about integrated planning, and then I want to take a little bit of a step back because that's the assumption everybody, and probably everyone does know, but exactly what do we mean when we say that? Like, what do we mean? Like, what do you guys mean when you say the integrated planning? So we're all on the same page of understanding.
Right.
So what we mean is that we want jurisdictions to look at what happens in terms of HIV from prevention along the continuum all the way to care. Our ultimate goal, of course, is not only to identify people who have the virus, but for those who do have the virus, we need them to be virally suppressed. We know the science tells us that if a person is virally suppressed, then there is effectively no risk of them being able to transmit the virus. And so we want to get people into care. And again, prevention and care and treatment, it all has to be, again, a part of that seamless care, we hope, for persons who need our services.
That's right.
And it really is focused at the population level, so it includes the entire population of people who know their status, as well as those who don't know and are at risk. The other thing I wanted to add is I think we need to be candid that there were also some challenges with the integrated plan. So I know I've been involved in a couple of conversations at the conference. So we had this integrated plan requirement, which actually comprehensive planning has always been a requirement. So this actually decreased burden because we combined everything into one document. But we know that jurisdictions have their ending the epidemic plans. And so is there synergy between the two, or is it a totally separate requirement? So I think we need to think about that as we plan for the next cycle. And then a number of the cities in this country have signed on to another initiative, which some of our viewers may have heard about, which is the Fast Track, City Fast Track Initiative that's sponsored by this the group IAPAC. And so they've signed on to that. So what does that mean, and how do all these things play together and ultimately get you to a better place?
Right. So this is helpful, but we want to talk about a question like, you guys are the experts. So what is the real difference between integrated prevention and care planning and ending the epidemic and getting to zero?
So, in my opinion, based on the jurisdictions that we work with, who many now do have ending the epidemic plans, I think the ending the epidemic plans are more aggressive, if you will, more intentional in terms of exactly really zeroing in, for lack of a better term. There are several jurisdictions that have programs where a person is identified and they're like immediately put onto treatment, because
Right.
there's
Right.
this kind of one-stop shopping, if you will,
That's
that
right.
exists. So there are different examples, I think, that jurisdictions
right.
have come up with that may not have normally have been a part
Right.
of what their regular
Right.
integrated planning process
Yeah, and
involved.
Right.
I think the ending the epidemic plans give jurisdictions more freedom to go where the data tells them to go, because in some respects our integrated prevention and care plan, since it was stimulated by CDC and HRSA, it's kind of focused on the operational aspects of our programming,
Right.
whereas in the ending the epidemic plan, you heard people are taking
Right.
chances and doing things that are a little bit outside the box in terms of following the science, but maybe
Yeah.
doing things that
Right.
we don't financially support around needle
Right.
exchange programs,
Exactly.
more aggressive prep programming, addressing non-discrimination laws and changing the laws within their jurisdiction.
Right.
So
Right.
really focusing at a much higher level and trying to move forward.
And I think the resource issue that you bring up is really critical, because you're right, in many jurisdictions, people aren't being heavily reliant upon CDC and HRSA funding.
Good.
Cities and states are also
Good.
leveraging funds
Good.
to be able to
So
help
that's that
with
true
the
partnership.
epidemic.
That's
Exactly.
that true partnership.
Right, right,
Absolutely.
right.
So what other things are going on at HRSA and CDC regarding, getting to ending the epidemic?
What, you want to start?
Sure. It's somewhat limited, but I would say that philosophically, so like our two biggest programs are our Part A grants to metropolitan areas and our
Okay.
Part B grants to states and territories. Ryan White is a $2.3 billion program. 83% of that money goes to the cities and states.
Right.
And so, and it goes primarily to state, city, county health departments. So they have that public health focus. So we're pushing them to not only be good stewards of our federal grant programming, but to really assume that natural population level responsibility and
Right.
build on the infrastructure of our grant funding
Right.
to take on these other issues that they might address in an ending the epidemic plan. And that's kind of exciting to see.
Yeah, that is. That is.
For CDC, in terms of HIV prevention, there are 60 jurisdictions that we fund. So those include primarily the 50 states, but also territories, including Puerto Rico and the Virgin Islands, and then several large metropolitan cities.
Right.
From a prevention perspective, we're really looking at 4 strategic imperatives, if you will. We believe that in getting to know new infections, if we ensure that people know what their status is, and increasing knowledge of status includes routinizing HIV
Yes.
testing. We still need that so badly.
That's right.
We need for clinicians, I think that question was raised this morning, how can clinicians help, in terms of trying to get us to know new infections?
That's right.
By screening. We simply need people or clinicians to make screening a routine part of a person's health care. We also want to make sure that we're preventing new
Right.
infections. We don't want to
Right.
forget primary prevention.
Right.
And so ensuring that we're still doing risk reduction activities, ensuring that we're still educating people.
Right.
We want to definitely reduce transmission.
Right.
So again, the whole issue that we talked about earlier in terms of getting folks to viral suppression, making
That's right.
sure that they're identified, that they get into care, that they get onto antiretroviral therapy, and
Yes.
that they stay in care and on therapy is
That's
like
right.
critically important.
That's right.
And then if we do detect that there are clusters, and that is starting to happen more and more around the country, if there are clusters of HIV that are happening, we want to make sure that, first of all, we detect those clusters, but
Right.
then also we interrupt those clusters.
Right.
So we do
Right.
that by detection, investigation, and response.
And Kay, if I could add one specific
Sure.
thing, we actually have a new notice of funding opportunity on the
Okay.
street.
Okay.
It's limited to current Part A jurisdictions, the
Okay.
eligibility for funding, and it's really technical assistance and capacity building money
Great.
to help jurisdictions that want to get started on an ending the epidemic plan or move.
Awesome.
So it's going to
Yeah.
support infrastructure support, community engagement,
Right.
maybe some innovative
Right.
programming, some marketing, those types of things to help people move forward and
Right.
get them off that first starting block, if you will.
That's good.
So we're looking forward to supporting up to 5 jurisdictions.
That's good news.
Yeah.
So viewers, I would be remiss because these two great leaders here have been working years in this work and have been doing such great work. So I really want to take a step in a different direction and want you to share sort of personally that over the years of working in this field that you think we'd be at this point where we're talking about ending new infections, ending this epidemic. give me sort of that personal, because you guys have been warriors in this work and have seen and been there. So I really want to hear from both of you on that.
Sure.
Yeah.
You want to go? Want me to go first, or
Why don't you go first?
Okay. So I've been in this work since 1984, and the best way I can describe it is that it's been a bit of a roller coaster. There have been significant ups and there have been significant downs. Personally, when I first started programming in New Jersey before I joined the federal government, it was at a point in time where the length of life from diagnosis to death was 9 months. And in fact, I worked directly for the Deputy Assistant Commissioner of Health in New Jersey, who I did not know at the time, but he had AIDS. And he passed away about 3 or 4 months after I started working for him. And I think early on, most of us got involved because we were impacted in some way. And I made a commitment to him back in 1984 that I would keep working in this field as long as I felt like I could make a difference. It's night and day in terms of where we are now. And, following Dr. Fauci, who, I think of him as one of the country's doctors,
That's right.
Really amazing how he, explained to us on Tuesday the scientific tools that we have in our toolbox now.
Absolutely.
And so we do have the tools. It's within our reach now to end the epidemic. It just will take the political will and the wherewithal and knowledge to target those tools and resources appropriate.
That's right.
But it really has been quite a ride, and I'm just grateful that I've been able to be part of it and make a small contribution. So.
Well, for our viewers, he's very modest, because what he didn't say, and what Janet and I will say, he was honored earlier today in the session for 30 years of distinguished service. So I just want to say congratulations.
Thank you.
Congratulations.
And
Thank
so
you.
it's such a pleasure for me to be here in this interview. So, but he wouldn't tell you that. I had to tell you. So I want to share with Janet any reflections as well.
Well, I think my reflections would be very similar to Stephen's. I actually started this work in 1987. We're both dating ourselves.
Pretty close, yep.
And it happened as a fluke, to be honest with you. I was actually working in an STD clinic in Cleveland, Ohio, and was assigned to a clinic in Lakewood, Ohio, to do evening clinics.
Okay.
And at that clinic, primarily white gay males were served at that clinic. And so there were these gentlemen that would come into the clinic at night, and they would have these purple sores on their bodies, and they would describe other things that were happening to them and began to educate us, because this was still primarily a bicoastal disease, right? So here we are in the Midwest in Cleveland, Ohio. And these men are coming in and they're educating the clinicians, the providers, the educators. They're educating us about this is what is going on.
That's right.
And life expectancy was, you're right, I would actually say 3 to 6 months. You're probably providing the science by saying 9, but I feel like it was closer to like 3 to 6 months. People would just be gone. And so these gentlemen became angels that I say still walk around with me. And my commitment was to finish my work in the community and go to CDC, because I wanted to make a difference at the national level. I said I was going to stay at CDC for 5 years, but then I figured out that populations like men who have sex with men, same gender-loving people, people of color, the disenfranchised communities that were most impacted by this disease needed advocates at the federal level. And needed people to be able to tell their stories. So that became my commitment. And I still get choked up about it. This has been my passion.
And could I add maybe another difference? So from the care and treatment side, if you look at the portfolio of services that were needed, I'll say way back when, it looked very, very different. And so we were talking about hospice services, a lot of home-based services, a lot of where can we find beds in long-term care facilities, how can we set up residential beds in therapeutic communities for drug users. So it was all, providing that support and bed and housing for people, whereas now we've really moved into a medical model, outpatient mode, dramatically different.
Never could have believed that we would have gotten here. I can remember funeral homes not willing to accept bodies.
And then the other big difference and why we're here, I think, is there was a separation between prevention and care in
right.
the early
Right.
years of this epidemic,
yes.
and
That's
now they are one and the same.
That's
prevention is treatment, and
Prevention
treatment
is
right.
is prevention. There's,
That's
there's
right.
no distinguishing
Right.
between the two. So.
Exactly.
Yeah.
So these
Exactly.
themes keep coming up. We hear themes. You're talking about partnership, engagement, listening, working together. We thank our viewers for listening in today. HIV.gov, you can go and get more resources and get information. And I just want to say a special thank you to
Thank
Janet
you.
and to Steve
Absolutely.
for being here.
Sure.
Thanks the viewers for participating with us. If you can go back and look at this later, I'd encourage it because it just makes you walk away with such a great feeling. So again, thank you. We look forward to hearing from you. Have a good day.
Thank you, Kay.
Thank you.